Friday morning. Good morning, everybody, and thanks for coming out to the March 23rd edition of the School of Population and Public Health Grand Round Series. I'm Jen Gardy, the faculty coordinator for Rounds, and it is my pleasure to welcome you here today. A couple of acknowledgements before we start. The first is that we are, of course, gathered on the territories of the Musqueam people, and the type of learning and storytelling and dialogue that we are all about to engage in has been happening here for millennia. For that, we are honored. Heichka, thank you. Our second acknowledgement, Alex, get back here. You're our second acknowledgement. Get in the door. We are losing somebody very special on our Rounds team. Many of you probably know that SPPH's fabulous communications director, Alex Walls, is leaving us. She's going traveling around South America and doing amazing, interesting, fantastic things. She put so much work into making this a fantastic event, whether it's putting together the amazing marketing materials, making sure that you can all join us in the room or online, getting speakers to hand in their slides is a huge task and generally a thankless one. So Alex, thank you so much for everything you have done. And I know if you're leaving the country, you probably don't want stuff. So here's some calories, because every traveler to South America needs to be fortified with energy. Oh, let's do it in front of the camera. Hey, everyone, check it out. It's a cupcake. There you go. You can eat it in here. Even though it says no food or drink in the MSL theater, you have my special dispensation. Go ahead and eat the cupcake whenever you want. You've earned it. So today's presentation is really interesting, and it's actually kind of a long time coming. I'll tell you the origin story of this. So back when we changed the format for SPPH Rounds, it used to be a weekly, one speaker, 45-minute research talk kind of thing, and this is now the second academic year that we've gone for this. Once a month, big picture topic, multiple invited speakers. So Alex and Chris and I were having a meeting talking about what do we want Rounds to look like in this new format, and who might we get for speakers. And one of the things that I was really excited about was the idea of bringing people in from other parts of campus whose work is really compatible with what we do here in SPPH. And as somebody who's personally really interested in science communication and journalism, it seemed like bringing in somebody from the Graduate School of Journalism was a really logical first step. And of course, we in SPPH are talking to the media all of the time. There's the President's Award for Public Education through the media. It goes to an SPPH practically every year. We are one of the most public-facing departments. So it seems natural that there's a synergy between the journalism school and the School of Population and Public Health. So at the time, I was thinking, okay, we've got to get the J School in somehow. And I knew, but they didn't know at the time, that the project you're going to be hearing about today, the $1 Million Meds Digital Journalism Project, I knew that it was that fall going to be announced as the winner of a Jack Webster Award for Excellence in Journalism in the Science, Technology, Health, and Environment category. So I had it in the back of my mind. I was like, oh, when they announce this big award-winning story platform project coming from UBC, we should have it come to SPPH because it ties in so perfectly with a lot of the work that many of our faculty members do. So that was about 2 years ago. It took that long to get everything sorted out and make this happen, but I'm tremendously excited for today's Rounds because we have two incredible speakers. My friend Peter Klein is the director of UBC's Global Reporting Center, former director of UBC's Graduate School of Journalism, and I think probably one of our first SPPH Rounds presenters to have an Emmy. Probably, you have multiple Emmys, don't you? Yeah, he's like, yeah, of course I have multiple Emmys. So cool. So Peter's going to be talking about the $1 Million Meds Project, its origin, kind of walking you through some of the stories, and then you're going to see how perfectly it relates to the work that one of our amazing faculty members in SPPH, Dr. Michael Law, is doing. Mike's an associate professor, and he holds the Canada Research Chair in Access to Medicines. His work is a perfect complement to the $1 Million Meds platform. It's going to be super exciting. So with that, let me turn it over to Peter Klein. Thank you.
Thank you, Jen. So I'll give you the brief origin origin of this particular project. As Jen said, I'm a journalist. I'm a long-term journalist. I work mostly for 60 Minutes and for New York Times and other organizations. Done a lot of years and years of coverage of medicine and pharmaceutical industry, issues around clinical trials, issues around access to medicine, the role of intellectual property and access to medicine, but mostly focused on the United States and global health, not in Canada. I moved here about 12 years ago, and maybe 5 or 6 years ago, Larry Lind, who's I'm so glad is here, from pharmaceutical science, approached me and said, I'm interested in doing research on access to expensive drugs for rare diseases, and I'm particularly interested in how we might be able to communicate some of these complex issues. And I'm not this kind of simplistic and stupid anymore, but back then I was still more American, so I was like, well, that's going to be the shortest paper ever. Canada has universal health care. Everyone has access to meds. At the end, like, you're not going to get that published. And he said, no, actually it's quite complex. There's issues of what drugs are covered, the cost of these drugs, the efficacy of these drugs, the issues around coming up with the prices. Individual provinces are negotiating with pharmaceutical companies. They don't have a lot of bargaining power. There's national bargaining, of course. There's more bargaining power with drug companies. And then one aspect that I've actually been very interested in, I've done a lot of work on the Orphan Drug Act in the United States, which similar laws exist now in Canada and the US. If public funds are used for developing drugs in the United States, the Bayh-Dole Act was passed in 1980 that allowed publicly funded innovations to be commercialized, and then the Orphan Drug Act added the additional incentive that if you develop drugs for orphan diseases, rare diseases, you get all sorts of other incentives. But the complexity there, just from a reporting or investigative reporting standpoint, is that all this public money is going into developing these drugs. So you have paid to develop this drug, and then God forbid you need one of these medicines, you then have to pay again, either out of your pocket or through your health insurance plan or through your taxes, which ultimately cover publicly funded medicines. So I realized pretty quickly that this is a pretty rich topic, and Larry put together a brilliant grant proposal and got a CIHR grant, pulled together some of the best people throughout the country, and asked if I would be involved as a journalist. I have no substantive knowledge in this area, but having reported on it, I was interested in it, and I had a number of graduate students who were actually quite interested in it. One who actually had a PhD, one who worked as a scientist for many years, so they had some aptitude to understand these issues. And they came on board on the initial round of this project, first year. So with the journalism students, what I started exploring is, okay, let's, Larry's bringing all these other amazing people together at workshops and writing papers and doing surveys and all of that stuff. We obviously want to highlight that and feature the important research that's being done, but let's also look at this as journalists, as storytellers. And very quickly we realized that one of the biggest challenges from a journalist standpoint on this topic is that you can talk to all of these experts and understand, if you do understand, some of those policy and even scientific complexities, and then when you trot out a little 5-year-old who has terminal rare disease, the conversation's over. There's no discussing policy or patents or access to medicine or the efficacy of this drug. If the drug is 1% successful in, slows down the degeneration of a terminal or degenerative disease, slows it down by a week, and it costs $1 million. Well, if you're the parent of that 5-year-old, I don't care if it costs $1 million. My child can walk for another week. My child will be alive for another week. It's a non-issue. So it was very difficult as we started reading journalism to get anything beyond the patient stories, these really heart-wrenching patient stories. So of course, this is ultimately about patients. This is not about policy. This is not about politicians. It's not about drug companies. It's about patients. If the patients didn't develop these diseases, this would be a non-issue. So of course, the patients are central to this. But how do you address this issue with some level of complexity while giving due to the challenges that patients face and and the urgency that patients have, while also addressing some of these more complex issues. So I was very fortunate that these two students were, more mature students and really thoughtful students, and we talked through this, and we brought in another filmmaker named Gary Marcuse, who is a wonderful longtime filmmaker in Canada, and we came up with this idea amongst all of us and the broader team of, rather than having these narratives, these very powerful stories, which might get eyeballs, we'll break it up. So I'll show you a little bit about how we developed this project. We went all over the country, actually went into the States as well with some of these Canadian patients, profiling their challenges, their struggles to get access to medicine. Obviously that's what is going to draw the general audience in. So I'll show you just a tiny bit of how we built this, and then I'll explain kind of our navigation. But it's interesting because I had come from a really traditional background of writing magazine articles and doing hour-long or 2-hour-long documentaries where you have to keep someone's attention for a long period of time. The web allows this new form of storytelling that really wasn't possible before, where you could allow the user to have some interface and really kind of bring things up. So we took advantage of that here. So I'll show you, well, there's a little trailer. Maybe I'll show you just a minute long.
They told me that he would never sit up to take him home and love him, and he'd be gone before he was 2.
You're doing fine, Craig.
Good job, buddy.
All of your hopes and dreams are gone. It's over.
Bye, buddy.
It's like burning everything to the ground and starting new.
The peculiar thing about rare disease is that it's common.
It was still all experimental, but the people that were getting it were doing really well with it.
If I wouldn't have got the drug when I was 13, I probably would have been dead.
Each vial is about $3,500. It's not a cure,
Trey, do you want to have more granola?
but we've got some space.
It's probably about $1 million a year.
Why does it cost so much? Does it equate to profits?
If I'm a manufacturer, I would look at my ability to return value to my shareholders.
How can you look at a child and say the drug's too expensive?
Today, depending on what province you live in, you may get access to a drug for rare disease, and you may not in other provinces.
But I'm not going to wait and let my child die for Canada to get its act together.
You've got to ask the question, well, if we spend it on this, what aren't we spending it on?
It's a difficult decision to make, and we're making these decisions in a thoughtful way. I'd be all in favour for making the process more transparent.
You can't put a dollar amount on a person's life. It's just not fair.
So, we certainly have the powerful narratives and the stories, but we also tried to put some voices of some of the experts in there. And so this was just a little one minute trailer. One other issue that came up, and then I'll show you the navigation in a moment, but one other issue that came up as we started reporting on this, and again, we're trying to enter this into this as investigative journalists and as explanatory journalists, is that there's some very powerful patient advocates. You've heard some of these here, and you understand, of course, why they feel the way they do. But it turned out some of those patient advocates, not these that you've seen here, but some of those patient advocates are actually working with the pharmaceutical companies. The pharmaceutical companies have approached them saying, look, your child has CF, or your child has MPS, whatever it might be. And the pharmaceutical companies, struggling to get this drug covered in your province, in your country. We want to have this story out there, how important it is to have access to these medicines. We will cover your costs to travel around, perhaps even give you an honorarium, significant honorarium in some cases, to advocate for access to that medicine. But now back to me as a journalist, I don't always know if someone's getting money. So then there's this additional complexity as a reporter of the conflicts of interest. Then are you going to ask a parent of a kid who's perhaps terminally ill, is the drug company giving you money for saying what you're saying? You're questioning, do they really care if their child is going to die? It added, it was not as simplistic as I originally thought. Let me put it that way. It was a really complex story, and from the standpoint of a journalist working within a university, it was great, because this is what we want. We want to basically fill the void of mainstream media. At the Global Reporting Center that we have here, that's exactly our goal, is to bring scholars and journalists together to take on big, complex issues, the kinds of stories that are not being reported on or not being reported on well by mainstream corporate media that is driven by eyeballs and readership. And this project fit that bill really, really nicely. So I'll just briefly show you how we decided to build this, and then I'll hand it off to Michael. So basically just we had a little sort of explainer explaining some basics. This is Linda Parr, a little sound. For some reason it's not playing for sound, but we had basically sort of a little.
I will not quit.
Little summary.
Until rare diseases is paid for across Canada, because it shouldn't be that, all right, Trevor lives in Alberta, so he's funded, but you live in Saskatchewan, so I'm sorry you don't get funded. We are supposed to be equals.
So on our introduction, we have a few basic facts. Canada pays at least 30% more than medications in other developed countries. And we have per sound, and then publicly funded national pharmacare may benefit Canadians and save money. And then essentially we just did kind of a very, very brief overview. And this is where I think there was some level of innovation in terms of thinking about this, and it really was driven by our students, where they said, look, the problem is that, as I said, the narratives of the patients take over. So how can we basically interrupt that hijacking of both the intellectual and the emotional connection to the story? So what we did is we decided to start finding these stories, different kinds of patients, adult patients, child. We have a child, we have someone with a very serious degenerative disease, we have someone with a fairly serious condition of cystic fibrosis, and we have an adult with Pompe disease. So we have a variety of different kinds of stories. They all have different videos, but then each video is short. So like here's, for instance, this is Trey's story. It's, I don't know, a minute, 2 minutes long. Essentially gives you the overview of their story. And then right when it's over, it then sends you to some context. There's three other pieces of Trey's story, which you can watch. We're not going to force you to have your vegetables, but here are our vegetables. Our experts are the people who can explain the context of what you just saw. What's a rare disease? What's this particular rare disease? How does newborn testing work? The DNA in rare diseases, and then you hopefully watch one of these or watch a couple of these, and then you can continue on. So as we might. So when
Trey was diagnosed, we knew there was.
As we might do in if I was making a documentary, what we call it a narrative thread. So you'll have the narrative thread of the powerful story. Trey and his mother's efforts to get medication. And does he get the medication? Does he not get it? Does it get better? Does it not get better? Is he going to live or die? That sort of, like a movie, essentially. On that narrative thread, you would kind of sprinkle some of these experts. But there's only so much of those experts you can really sprinkle, and speaking as a filmmaker, it often really interrupts the flow. Imagine you're watching Star Wars, and in the middle of Star Wars, some expert starts explaining the scientific context of what's going on. The reason we're able to fly, at certain speeds is because of certain physical properties. It would kind of screw up that movie, and that's the problem from a storytelling standpoint, from a journalism standpoint. So we decided to kind of break this up and have these different expert voices in here, and you know, the truth is, in this particular project, we had we made a conscious decision that this is not going to be, we weren't looking for millions of people to watch this, you know, because we're not a commercial entity. We're not, you know, living and dying by our ratings or by our clicks or views. We had a very specific audience, people who care about rare diseases. But what you know, I realized working with the scholars who are part of this bigger project is that really, first of all, rare diseases affects a lot of people. If you start looking at, you know, as one of the experts said, you know, the funny thing about rare diseases is they're not that rare. Each disease itself is rare, but in aggregate, they're quite common. Many of you probably know someone, or perhaps even have a rare disease. But the other part is that, of course, it affects everything. You know, we're all part of this healthcare system in a really simplistic and extremely simplistic way. You know, if you're spending $1 million on medication for someone with a rare disease, that's potentially $1 million out of the healthcare system. You know, and then the question is, what is that $1 million getting that patient? If it's slowing down, you know, their macular degeneration by 5%, is it worth $1 million? Is it worth potentially delaying the MRI that might predict a brain tumor of someone? It's not a correlation quite like that. I mean, it's much more complex the way the buckets of money, but on a really sort of simple level, you can see that argument being made. So what Larry and I and a couple others in the team decided to do is have a town hall. So in the fall, we're actually going to have a town hall. We actually just got permission from the BANF, the International Research Station there, to host a town hall in which we're going to bring hopefully all the stakeholders, as many stakeholders as possible, the patient advocates, the pharmaceutical industry representatives, the people who ultimately have to make the decisions for provinces, what drugs are covered and not covered, the clinicians, the whole and pharmacoeconomists, a whole range of folks to a town hall that will be moderated, and we're going to discuss these issues in a public forum. We're hoping to partner with CBC and actually broadcast this, perhaps even live stream this in some form, so that we can bring in voices from all over the country, because it is an issue that affects all of us. It is ultimately public policy. It's a complex issue. It's one that doesn't have necessarily a visceral connection to a lot of people, but we realize that there's a value here to bringing the entire country into this conversation, and that's the only way things are going to kind of advance. And then the latter stage of this project, hopefully not the latter, the end of it, but the next stage is looking globally. So we said, okay, well, now we've looked at what's going on in Canada. We have some handle on this. That's some great scholarship that's come out of it, some great surveys that have come out of it. Both professional scholars and students have gotten some fabulous experiences from this. But what we realize is that all these different countries around the world have come to their own solutions, sort of in quotes, on their own, very often without even talking to one another. And when I've talked to people about, you know, since I do mostly global journalism, when people have seen this project on our website or heard about it, they would talk about what's going on in their country, and they have no idea what Canada does or how, you know, what strengths Canada's policies have, what weaknesses Canada's policies have. So we're going to be, as I like to say, we're bringing the Larry Linds of the world together, and from Australia, New Zealand, and France, and England, you know, basically countries that have somewhat similar healthcare systems, public healthcare systems with universal access, and looking at comparing and contrasting how all these different organizations or countries deal with this issue. So that's sort of, stay tuned. I don't have a really good sense of how all that compares, but the first step is to actually get some data, and we're gonna analyze that data and get sort of a baseline of how different countries approach this. And again, we're then back to the policy level, and then we'll dig deep down into the patient experiences in these countries as well. So hopefully that's a good overview.
Amazing. Thank you. as we do our little change over here, I'll remind everyone that we'll do questions at the end, and we'll do questions via the room, we'll do questions via Adobe Connect, and questions via Twitter. Use the hashtag SPPHrounds to ask any questions you might have. And now that the computer is being magically switched over, I'll turn the mic over to Michael.
Thanks, Jen. It's always really great when you get to follow a really engaging and super speaker with a topic that you know is less interesting. Anyhow, I'm going to present the results of a paper that our team at Chesper's worked on over the last few years. And the topic is the consequences of patient charges for prescription drugs. So it's related in the sense that a lot of patients in Canada do spend a lot of money out of their own pockets on prescription drugs. It's different in the sense that these drugs that I'm going to talk about are different. These tend to not be the big ticket, newsworthy, $700,000 or $1 million a year type of drugs, but the drugs that people are taking on a more regular basis for a lot of chronic conditions and whatnot that affect big swaths of our population. So the genesis of this project was in a lot of prior work. So we know from prior surveys that have been done by both Statistics Canada and the Commonwealth Fund and a number of other groups that a significant number of Canadians have trouble affording the prescription drugs that they're given by physicians or other healthcare providers. And so the numbers in the past have ranged from about 10% to 12%, depending on the survey, of people who have a prescription. But those past surveys were pretty unsatisfying in a lot of ways because we didn't know a lot of things about the actual behavior. We knew how many Canadians were doing it, but we didn't actually have a lot of data on what it actually meant. So the phrase that people use in the literature is cost-related non-adherence. So it's not taking something because of the costs. And we didn't have good information on what drugs people were foregoing. So we didn't know whether they were foregoing things like an antibiotic for an infection or a cardiac medicine that they were to take long-term. So we didn't actually have a good sense for whether or not there were particular types of drugs that people were having trouble affording. We didn't know how often people were engaging in cost-related non-adherence. We didn't know what the price was that mattered. So I often get this question from policymakers, how much are people able to pay? And the frank matter of it is that we don't actually have a good sense of that. We don't know whether it's $5 or $10 or $500 that really constitutes a barrier for people. We didn't know what people were trading off. So I have the plate of spaghetti here. We didn't know if people were trading off food for prescription drugs, heat, or other things like that because of their drug costs. We didn't know what insurance rules mattered. So whether it was an upfront deductible that people had to pay or whether they had to pay a small amount out of pocket for each prescription. We didn't really have a good sense. And we also had some sense from other literature in a sort of tangential way, but we hadn't actually asked people about what health impact not adhering to their drugs had for them. In pilot testing, when we were working on devising our survey, we actually dumped the insurance rules because it turns out that if you ask people about the terms of their insurance coverage for prescription drugs, they have no idea what you're talking about. So that was a valuable lesson for me in survey design, but we did manage to do the others. So what we did is we worked with a group at Statistics Canada that runs the Canadian Community Health Survey, which I'm sure most of you are familiar with. And we designed what's called a rapid response module. So it's a module that StatsCan adds onto the end of the CCHS, and they field it as part of that. So you gain the advantage of getting access to all of the other variables that they ask about, and then you just add on what you want. And when you design one of these things, you get to ask about 5 minutes worth of questions, and it costs a fortune. But you do get the ability to field it through StatsCan, because when you do that, you get good response rates, you get to work with their team that develops surveys all the time, and you get all of the other questions they ask. So you don't have to ask the questions like, how old are you? What's your health status? All of those things are taken care of by StatsCan. So we fielded this over the first 6 months of 2016 after a couple of years of development with the group at StatsCan, and ultimately fielded our module to about 28,000 respondents from across the country. And we surveyed people who were 12 years old and above. So the first question we asked people were these two questions, and this was really to get at the issues of cost. So during the last 12 months, was there a time when you did not fill or collect a prescription for medicine or skipped doses of the medicine because of cost? And then the second question was, in the last 12 months, was there a time when you reduced the dosage of your medicine or delayed filling your prescription because of the cost? So trying to get at different forms of non-adherence due to the cost. So across Canada, about 5.5% of people say yes to either or both of these questions, or if you take just the population who reported having a prescription, about 8.2% of those who were prescription. The rates vary across Canada, so you can see Canada here is at 5.5%. Here in British Columbia, we have the highest levels of cross-border non-adherence in Canada. The question often comes up as to whether or not I think this is a consequence of our public drug coverage. I think it probably might have something to do with it, but it probably has more to do with the cost of living in British Columbia. So if you look at it, but I'm not just joking about this. If you look at levels of personal debt and whatnot, we're worse off in British Columbia than elsewhere in Canada. Quebec has the lowest rates of cost-related non-adherence in Canada, and that probably has to do with Quebec's insurance setup, which does provide coverage for everybody. And I can get into details if people want to get into it, but there's a sort of social insurance scheme in the province where everybody either has public or private coverage. These things vary a lot on a number of characteristics that people would probably think that sort of make sense when you think about the policy setup we have in Canada for prescription drugs. So the lowest rates you find in children and also in older adults. And this probably has to do with the fact that a lot of people in the elderly groups, particularly in provinces like Ontario, have pretty good public coverage for medicines. The group between 19 and 34 is by far the highest rate, which also makes sense. Lower income, working poor individuals without private drug insurance would tend to fall into that group more than others. People in worse health status report much higher issues, much more frequent issues with drug affordability. Those with lower incomes, again, none of this will be a grand surprise, but the scale of the differences is pretty significant. You're talking about 3% versus 11% between these different income groups over the spectrum. Something that was new in this survey that we hadn't seen before is we actually had enough power to look specifically at different ethnicity groups. So people who self-report as Aboriginal have by far the highest rates of cross-border issues with medications access in Canada. This finding got quite a bit of kickback from some people because what's called the non-insured health benefits scheme, which is the federal plan that covers Aboriginals, is actually quite generous. There's a lot of issues with how that scheme is run, and actually only about half of people who self-identify as Aboriginal actually qualify for that scheme. One of the most obvious factors involved here was the presence or non-presence of prescription drug coverage for people. Again, not surprising. People who report not having insurance are more than threefold more likely to report issues with drug affordability. So this stuff is all more or less what we already knew, right? So there's about 1.7 million Canadians that are reporting these issues, or 5.5%. So then we dug into the questions where we tried to expand out and think about some of those other issues in the pictures at the start, which are the things we didn't know before. So what health conditions were these prescriptions meant to treat? So when someone said they had trouble affording one or more of their medications in the last year, we asked them about the prior time that happened. So the last time you couldn't afford something, what was it intended to treat? And we found that it really was all over the map. So the most common were medicines for depression, anxiety, or other mental illnesses at about 331,000, but we have a whole mix of things with basically everything showing up with a significant number of people. So these are population totals estimated from the survey, right? So we take the number of people who reported yes in the survey and then scale it up to the national level. And you'll notice that other condition here is quite massive. So people didn't fall into one of these categories with the drug that they couldn't afford. The next question we asked was, how much was this prescription going to cost you? Please exclude any amounts that were reimbursed by an insurance plan. So what we were trying to get at here is how much, that barrier question. So how much cost were people actually facing at the pharmacy, and what formed a barrier for people in terms of affording their prescription drugs? And interestingly, what we found, we expected this chart to look a little bit more, more like a curve. But what we found is that actually the vast majority of people who were reporting issues with cost, the last medicine that they couldn't afford was between $50 and $200. So it wasn't the big out-of-pocket expenditure that one might think of, but really, in prescription drug terms, this is a pretty routine prescription. Most brand meds would end up there, even if they're not one of the expensive drugs that we were talking about earlier. And then to get at some of the health consequences, we asked the following question, was did being unable to afford your prescriptions result in you having to do any of the following? Select all that apply. And we asked specifically about 3 things that people tend to do in healthcare because they can't afford their prescription drugs. We asked whether you went to an emergency department, whether you were admitted to hospital, or whether you saw your physician when you wouldn't have otherwise. And about 93,000 individuals, obviously scale up from the survey, reported going to the ED, about 26,000 reported a hospital stay, and about 300,000 reported a physician visit. This is obviously self-reported, right? This isn't going to be a straight-up causal relationship, and it's hard to establish causality with these things, but there are a fair number of Canadians reporting healthcare utilization in other areas of the system because of issues with the affordability of prescription drugs. And then the final question I'm going to talk about, in the last 12 months, have you or anyone else in your household ever spent less on any of the following in order to pay for your prescription drugs? So trying to get at this issue of what people are trading off in order to pay for medicines. And here we found pretty significant numbers in a lot of these categories. So over 700,000 people in Canada are trading off food in order to afford prescription drugs, 200,000 housing costs, 238,000 heating, 375,000 transportation, more than 800,000 vacation and leisure, and 238,000 reported spending less on other healthcare expenditures. So they're spending less on other things that wouldn't be covered by the standard healthcare system. So overall, we found out-of-pocket charges lead to cost-related non-adherence, health consequences, and trade-offs with other spending. The impacts, so we did a lot of modeling, and if you're interested in the regression results, you can read the manuscript. But the impacts of all of these things were largely more concentrated in females, younger adults, the uninsured, Aboriginal peoples, and people who are sicker and poorer. The paper is published in CMAJ Open. If you want to have a look, it's available online. It was published last month, I think. And that is all I'm going to talk about.
So we've got a couple of housekeeping slides where we remind you of how question period is going to unfold. Housekeeping slide number 1. That worked. You can ask us questions on Twitter. There's been some fabulous tweeting about these presentations, so just use the hashtag SPPHrounds. I have my tiny device here, so I'll be able to track questions that come in. And some reminders as well before we go into the question period, that those of you that want CME credit, there is a survey that you can fill out for this. The learning objectives, which you'll have to recapitulate for the CME credit quiz, hint, hint, write these down, and conflict of interest. There we go. So let me put this slide back up. Actually, I'll leave the CME credit slide up. So let's turn it over to the room and to online for questions. I'm going to take a host's prerogative to ask the first question. And this is a question for both Michael and Peter. So maybe I'll get both of you up here because we have no idea who's going to get questions in what order. But my question is a 2-part question. And so it is to Peter, as a journalist who works with academics regularly, what one piece of advice would you give to the academic audience around communicating with the media? And Michael, as an academic who frequently talks to the media, what would your piece of advice to the room about working with the media be?
I mean, this is going to be an extremely obvious piece of advice, but it's something that a lot of academics, and I deal with academics all the time, just forget that the person you're talking to has not spent 5 decades of their life studying this issue. They've never heard of it before. So just assume an unbelievable level of ignorance in the audience that you're talking to. It's not to say you should talk down to people, and that's always the challenge that we have as journalists. We don't want to be talking down to people, but we also don't want to assume lots of information because then they're going to be lost, they're not going to understand and appreciate this. And I mean, this is as obvious as this is, it's the biggest challenge that scholars have, because of course they're so into it. And I will say on a journalism level, I mean, you've done journalism, you know, you spend a lot of time, and I see a couple journalists in the room, you know, you spend a lot of time reporting on even just your little story. You never heard of this topic before, and you just spent 3 or 4 weeks reporting on it. Even journalists have a hard time then saying, okay, well now I know all this stuff, and we throwing around terms, and so we all have this problem, whether you're scholars or not scholars. When you get deep into something, you understand it, you're passionate about it. Stepping back is the hardest part, I find, and that's kind of what we try to do as journalists, and ask those tough questions and say, you know, and almost every sentence say, stop. What does that term mean? Stop. What does that acronym mean? Stop. What's the context here? And that process can be useful.
So my advice is exactly the same. And so every time I have a paper or I'm going to talk to a journalist about something that we've published, I have a conversation with my wife the night before where I tell her about that paper and I tell her about the results. And she'll look at me, and my wife is smart, but she's not an academic, so she's perfect for this. And she'll look at me and she'll say, no, acronym, no, confusing. And she'll help me like pare it down and simplify it into something that's straightforward and understandable by somebody who's not, you know, digging deep in the field. So I hate to give the same answer, but it's the same.
Amazing. Convergent evolution. David.
Is there a mic?
Yeah, I'll run it over. Phil Donahue style.
I'm Dave Patrick. I'm not a journalist, but I had a fever dream on Monday night about the editor for the Globe asking me what I was writing. It's a long story. But the question here is really about the tension between these concepts. So Mike and Steve Morgan and others at Chesper have been pushing on this national pharmacare sort of thing. At face value, it looks like there's a tension between funding that and funding more expensive things like orphan drugs. I'm asking both of you guys, is it necessarily zero-sum, or is there some possible synergy in finding solutions to both these problems?
I was kind of hoping, since you were closer, is there? I think there's certainly there's something to be said. So a national pharmacare plan. If you were to have a universal pharmacare plan that covered everybody, that was standard, I think for many Canadians that would be beneficial, and for many Canadians that would be detrimental in terms of these expensive drugs. So let me explain why. The Canadians who fall into the sort of 40% of people who don't have a private drug plan right now, for them, the consistency and the ability of governments to better negotiate, and the ability of governments, and Bob will sit back there, Bob Nakagawa, who used to work for the province, will say you have to say no in order to get better prices, and a national plan would be better situated to do that. So in that sense, there would definitely be a benefit in terms of access to the expensive stuff. For the people with private drug plans, though, for the most part, those plans cover anything that requires a prescription in Canada. So I think, you know, people talk about this as a way to kind of improve access to those drugs, but I think for many on a private plan, were their employer to drop the plan if something national came into effect, they would probably actually be worse off in terms of accessing some of these drugs, particularly those for which government would be more likely to say no. So the drugs that do only, you know, improve things by 5%, or are only, you know, they extend life by an average a week, because those are the things that you would have to say no to in order to get those better prices. So I think that there's a bit of a mix in terms of where that would land.
And yeah, I'll just sort of a little bit outside my specific area of knowledge, but I will say I don't know if Bob was involved in the decision on Vioxx. Were you involved in Vioxx? Okay, so this is before I lived in Canada, and I was reporting on Vioxx. And everybody was talking about this place called British Columbia, which, you know, Americans are stupid. So this place called British Columbia that happens to be in North America, that like kind of heroically prevented people from getting sick, and really brought the scrutiny that was necessary that so many other places didn't. So not just one specific example, but a benefit to the localized process. On the other hand, when it comes to expensive drugs for rare diseases, having national bargaining power obviously is is hugely valuable. I mean, there's lots of ways of doing that beyond just a national pharmacare. But that's, from the standpoint of expensive drugs for rare diseases, more power for bargaining obviously is going to be beneficial to the public.
Other questions from in the room?
Hi, Charlene Black from the School of Population Public Health. It's a question about some of Mike's graphs and interpretation. I was really interested in combining an understanding of the average price of a foregone drug is within the range of $50 to $100. But a lot of your graphs showed that I'm looking at distributions by income, by insurance status, that kind of thing, showed kind of a baseline. 3% of the population identified as not being able to afford a drug. And that was for people who had employee benefit plans and for people who earned incomes of greater than $150K a year. So, that sense that 3% of the population in very, very good circumstances still is foregoing drugs because of cost was really interesting. Can you help me understand that and interpret it for me?
Okay, so let's start first with the sort of question about baseline. And so you're right, there is a baseline of a few percentage points in every category.
But it's not zero.
Yeah, that's not zero. So this makes sense if you think about, most employee benefit plans require people to pay 20%. So the typical split is 80-20. So if I fill a drug that's $100, I've got to pay $20 out of my own pocket. And ultimately, every purchasing decision somebody makes is going to be a trade-off against other things that they can spend that money on, right? So we've done some qualitative work on drug affordability. We found that the people were making very complicated decisions about what they thought was necessary, what they were seeing benefit from versus not seeing benefit from. And they were making choices across a whole basket of medicines that many of them were taking, because many Canadians have a whole slew of medications that they're on at any given point in time. And people were making pretty complicated trade-offs about what they were going to spend that money on. So if their out-of-pocket costs were adding up to quite a bit, they were choosing one of the drugs and saying, well, this one I'm going to leave out, and I might come back to it later if it affects me. We saw that across a lot of income groups. So you always have to think about it at the margin for an individual. Most people, even on private benefits plan, pay something, so for them the trade-off was obviously just not worth it. Honestly, I've had this debate with people at Health Canada. They wanted me to quantify at one point the total value of drugs foregone across related non-adherence in Canada. And I said, you shouldn't do that. Because there's drugs that people don't take because of the cost that you probably don't want them to take. Like if the cost isn't worth the benefit that they're getting from it, then fine. But identifying which ones those are is a really difficult task.
Okay, we have an online question. So this question is there any ability to compare how Canada is doing relative to what New Zealand is doing? They are a country that has the lowest drug prices of a study of 10 countries with universal health care coverage, a study in which Steve Morgan was the lead author on. I just followed the Twitter links through the paper. This may be a Steve Morgan question, I don't know. And yeah, any ability to compare how we're doing with a country like New Zealand? Is there something they're doing there that we could do better? I assume this is probably my question.
Sure. They're very aggressive. They have a national organization that does drug purchasing. They're very aggressive and they say no a lot. Yeah. And it's something that we're getting, frankly, better at in Canada. So we, in the last, say, 10 years, have done national purchasing through what's called the Pan-Canadian Pharmaceutical Alliance, and the provinces have come together. They're more consistently saying yes and no in concert with one another, and so some of those lessons are definitely being modeled here. One of the other things they do on the generic drug side is they tender very aggressively and get manufacturers to compete with one another. We have not done that in Canada, and as a result, we're probably still spending, or still leaving a lot of money on the table that we ought not to be. But the lessons are there, and they're things that Canada is doing, just not as well, because we haven't been doing it for as long.
Thank you. Other questions from in the room? Yeah.
I can see how the bargaining power would apply to common drugs, but there's been this discussion of rare diseases, and I'm just wondering, would that result in companies actually increasing their prices, or I just don't see the same sort of bargaining for rare disease drugs. I just wondered what your comments are on that.
You know, I would really defer to some of the folks like Larry in our team to give a definitive answer on that. But from what I have seen, in Europe they have been able to lower the price of drugs for rare diseases with bargaining. And I mean, this is a big issue. This is an ongoing issue, still unresolved in the United States with Medicare, where Medicare is not allowed to bargain because of lobbying from the pharmaceutical industry. He's basically twisted the arms of members of Congress not to allow Medicare to bargain. And it's I mean, again, now we're getting a little off on rare disease, but there are rare disease drugs amongst that. And I know that the predictions in the United States are that if they were able to bargain better, they'd be able to bring down the prices of both the orphan drugs and traditional drugs. I mean, there's the other part of this, and I just touched on it very briefly, which is the public funding. And particularly in the US context, if you start looking at how much the National Institutes of Health puts into developing these drugs, and then the additional incentives that the Orphan Drug Act provides to these companies, there are drugs. I mean, we looked at one drug recently, one of these orphan drugs, where it looks like there was $10 million put in by the drug company. $10 million. And that's all they put in. Everything else is public funding. Well, and they're charging in the hundreds of thousands of dollars per year per patient. So, you know, the challenge is to be able to prove that, because the way that the companies report their numbers, they mix things together, there's marketing. I mean, it's quite opaque. So it's an investigative reporting challenge as much as it is a scholarly research challenge.
Marketing and research.
More questions from the room? We'll go to Amy and then Dave.
Okay, I have one for each of you. So Peter, I'm just curious, this sounds, I'm trying to understand where investigative journalism and the research, where the line is, and because it seems like now that you're moving, planning that conference or workshop in Banff, and I'm curious what you think of this kind of model for doing implementation science, which I know is a new field catchphrase, and whether you think that this is something that is a model for other people, especially when they're working in a field where you're getting very close to policy change, or you're getting very close to, having to convince policymakers or stakeholders. So that's your question. My question, since we have a few students in the audience, and I'm so glad to see them here, I wonder, because you were mentioning that the survey is kind of one of the first steps you take to defining this question and what you would do to get at causality. Is the next step actually an intervention? Or what is the next design to demonstrate, to take what you have now to demonstrate whether support for a drug plan would do what you think it would do for all of these choices that individuals are making.
So I mean, there's a couple things that we're trying to do with the Global Reporting Center, with lots of different research clusters across campus and around the world. And I think part of it is the bringing together the scholars and journalists. So as you say, there's this area that, if you imagine a Venn diagram, like there's an area of overlap, and sometimes there's a fairly significant area of overlap, sometimes there isn't. And one thing that we've been able to do as investigative journalists is bring our investigative reporting approach, our methodologies. Sometimes even, frankly, our freedom within an academic system, because in many cases we're not beholden to the same bread and things like that scholars are. So we're able to use investigative reporting techniques and, to gain data that then the scholars can use. So that's the sort of first part. It's the public engagement part that I think I'm really excited about, particularly with this project, because we're able to, sort of like what scholars do when you do research and then you go back and you do checkbacks, we're doing this sort of mega checkback with the public. We've done this research, we found these stories, we've gotten this data, we've all this, and now we want to put it to you. This is what we found, what do you think, what do the different stakeholders think, and then try to advance that. And engage a range of policymakers. And I mean, we don't want this to be the Maury Springer show, where everyone's yelling at each other, right? And it easily could be that, because I mean, some of the people even that are in our project are quite strident in their feelings about these issues. And so, we have to be the one in the middle there, kind of modulating this and getting conversations going rather than shouting. Because I mean, the pharmaceutical industry is always gonna, they're gonna walk in with a black hat, right? And they're not Darth Vader. I mean, they're trying to develop drugs to save lives, but there's some problems with how they function. So it's finding that kind of grayer area in all of these areas, including the patient advocates. As I said, some are getting paid. So then you start questioning their motivation. So bringing all of that out in a public forum, we'll see. Who knows? Maybe we'll be throwing tomatoes at each other.
So those students that you're mentioning, I see quite a few of them that are taking my class right now, and they'll know that by this point in the semester, that in order to do what you're talking about in established causality, you think about interventions and things that have changed, and you look at what the impact of those things has been. So there's been a couple of instances of pretty significant change in drug coverage in Canada, particularly public drug coverage. So in BC, as part of the budget last month, they announced changes to the deductibles that patients will face, and so they raised the lower threshold for actually having a deductible. They doubled it from $15,000 to $30,000 of household income. So there's going to be a population there that, as of next year, will have very different public drug coverage than they had in the past. Similarly, in Ontario, the government recently, I think last year, introduced full drug coverage for children under 25, and just recently have announced that if re-elected, they will enact the same thing for people over 65. So these sorts of changes are the types of things that one can use to try and get at that issue of what actually happens when you turn the switch. Because the students who are in my class are now in week 11, sick of hearing me talk about selection bias. They're just wishing for reprieve at this point. So I'll only mention it once in this response.
All right, Dave, you get a 30-second question to finish things up.
So globally, we've seen breakthroughs on access to essential medicines like for HIV and TB and so forth because of massive philanthropy. Is there a present or future role for philanthropy in dealing with orphaned drugs as a bundle rather than as individual entities?
Good question. What's this
Tough question.
It's a very tough question, and so I'll push back on the question a little bit in that it was not only philanthropy that it was also India, and it was India's at the time laws. I mean, they still linger in some ways, but allowing them to make patented drugs inexpensively, $100,000 drugs, HIV medication in a single pill, Ohtuvayre, for $300 a year. Which then pressured, and then the philanthropists came in. So it was kind of they tag teamed those companies. You still have that happening on the expensive drugs for rare diseases, where you have drugs from India. I just did a project last year for the New York Times and profiled a woman in Florida who's getting a drug for expensive cancer drug for a rare form of cancer that she gets from India. She gets it on the black market, but lots of people are still getting their drugs through generic versions of patented medicines. So that seems to be one method that some people are getting around, but I mean, obviously it's very ad hoc. The philanthropists have not taken a lot of interest in this particular issue that I've seen, and I mean, I've talked to a lot of the foundations that deal with these issues, because there's so many big issues, whether it's rare disease, whether it's access to life-saving drugs, or malaria, or, I mean, you just say TB, and now we have multi-drug resistant TB. There are so many big issues that are kind of sexier to philanthropists. So at least what I've seen is that's really where they've been focused, and they're kind of hoping that the rest of us sort this out, you know, without having to get them involved. That's my sense of it.
I agree. Most of the focus globally has been on diseases that are much more common.
All right. Thank you, gentlemen, so much. That was extraordinary. Thank you all for coming out. Fill out the survey if you need CME credit, and have a super duper Friday and a wonderful weekend.